Alberta nag-discuss about ACA. So it involves the medial parts of the anterior circulation or anterior hemisphere on the frontal and parietal lobes. So if you have an occlusion in the ACA, this is how the stroke would look like. Nasa middle part. So these patients would present with contralateral weakness. And the weakness would be more on the legs compared to the arms and the face. Nga naman. Why? Because of the homunculus. If you remember the homunculus in the motor cortex, the control for the arms is located medially, while that of the face and the arms are more lateral. So in an ACA infarct, di ba medial man? So naturally, the leg would be more weak or would be weaker compared to the compared to the arm and the face. Aside from that, patients would also present with contralateral hemisensory loss. They could have urinary incontinence, abulia, meaning the patient may have no expression or apathetic. They could also have non-fluent aphasic symptoms, especially if the dominant or the left hemisphere is involved. And they may also present with sudden personality changes. So kung naay mga sudden personality changes, it could still be stroke. So you have to do a cranial CT scan to rule it out. Namoy mga lahi po ng bukalitrag tukar ha. So that's how an ACA stroke would present or manifest. So how about the MCA? So the MCA occlusion, it would really depend on which segment of the MCA is occluded. So let's start with a proximal occlusion. For example, if M1 is occluded, or this horizontal segment. So the patients would present with, of course, contralateral. Usually it's the opposite side. So if there's a right MCA stroke, the left side is weak. And this time, it's the arm and the face that is weaker compared to the leg because, again, of the homunculus, the motor homunculus. And they also present with contralateral numbness. Now they present with visual field deficits because this stroke, since it is proximal, it has a larger territory, so the strokes are also bigger. So the parietal lobe is involved. That's why they present with visual field defects, usually homonymous hemianopsia. They also present with aphasia, especially if the dominant side is affected. And then if the right side or the non-dominant hemisphere is affected, they present with hemineglect. Okay? And since these are large territory strokes, these patients usually come to the emergency room drowsy. Not all, but some would come in with decrease in sensorium. So that's for the M1 occlusion. How about if only the superior division is occluded? So it would result in a stroke, mainly in the frontal lobe. So these patients would present with contralateral weakness, arms more than the leg, contralateral hemisensory loss, and then they would also present with motor aphasia. So the frontal lobe is affected, so it's really the Broca's area that is involved. That's why they have difficulty speaking, but if you talk to them, they can understand. If you ask them, "What's yung ngalan?" Saka imo kamot. They can follow because they can understand spoken words. But if the inferior division is occluded, then it would involve more of the temporal lobes. So these patients, they present, since temporoparietal involved, they would present with visual symptoms, usually homonymous hemianopsia, and then they have sensory aphasia. So they are fluent, they can talk, but when you talk to them, walay sense. Okay, they don't understand what you tell them. Okay, so it's really more of Wernicke's aphasia. So di ba, amazing ang brain? Kasi mo agree. So the brain is really amazing. So do you remember during our discussion on the MCA, I mentioned the lenticulostriate arteries. These are small arteries arising from the M1 segment of the MCA. So if there is occlusion in these arteries, it would result to a stroke in the deep areas of the cerebral hemispheres, usually the basal ganglia and the internal capsule. So these patients would present with contralateral hemiplegia or hemisensory loss. So transcortical aphasia, they may also present with aphasia if the dominant side is affected, but kuan siya, kanang it's transcortical. Sometimes they have difficulty speaking or understanding, but when you ask them to repeat, they are able to repeat the words that you say. So that's how you test for transcortical adhesion. And then, of course, if you see here, klaro ba? But anyways, it's just, it's subcortical, meaning it's deep in the brain, so the cortex is spared, so cortical abnormalities are usually absent. So, wala to ang anterior circulation. Of course, ang ICA, combined ACA and MCA. Okay, it would involve both arteries. So, if the clinical presentation would be combine the ACA and the MCA clinical manifestations. So for the posterior circulation, let's start with the PCA. So PCA, they can check supply. So one is the occipital lobe. So if there is an occlusion in the PCA, this can present with occipital lobe infarcts. So they present, since occipital lobe, the function of the occipital lobe is vision, they present with homonymous hemianopsia with macular sparing. Or sometimes if it's just small, it could be just quadrant canopsia, either superior or inferior quadrant canopsia. So the PCA also supplies the midbrain. So if it causes a midbrain stroke, these patients will present with an ipsilateral cranial nerve 3 palsy, meaning there's ptosis, and if you lift the eyelid, the position of the eye is usually down and out. Or yes. And then they would present with a contralateral hemiplegia. So ang patient pag-anak. So kita nagkagabi yung diri na pag-human, there's weakness on the contralateral side. Ooh, Weber's. Expert na kayo. Okay, so that's a PCA stroke. So, what if the ICA or the anterior inferior cerebellar artery is occluded? So, it would result, di ba, ICA supplies the pons. So, it would cause a lateral pontine stroke. So, there is dysmetria. So, the patient cannot do finger-to-nose test on the ipsilateral side or on the same side. There is sudden hearing loss. Okay? And there's Horner syndrome. So, the patient might present with partial ptosis, meiosis, constricted and pupil, and no, they do not sweat on the same side, so anhydrosis. So if you just check your patient, sometimes you can catch this if you just pay attention to the details. And then contralateral thermoanalgesia. So most of the symptoms are on the ipsilateral side, but they would compare of numbness on the other side. So kubok lagi akong dito per numb akong other side. So this is very characteristic of posterior circulation strokes. Crossed ang signs. There's some signs are on this side, other signs are on the other side. So when we have cross signs, you always think of something in the posterior circulation. So what if the pica? So this supplies the medulla. So these patients would have medullary infarcts, which would present with vertigo. They really complain of dizziness, nausea and vomiting. They have numbness, weird ni ilang sensory deficits. They have numbness on the face, on the ipsilateral side, but their numbness on the body is on the contralateral side. So this would give you a clue that the stroke is in the medulla. And they also present with Horner syndrome. So daghan pa kaayong syndrome sa basig maabtan tag-ugma. If we discuss also, these are, I already mentioned the more common ones, but sa posterior circulation, there are still a lot. So just to emphasize, you always think of a posterior circulation stroke if the patient presents with motor or sensory signs that are bilateral or crossed, dizziness, pagpipong gani kaayo, suka, always think of posterior circulation, but not all the time, but you have to consider a posterior circulation stroke. Ataxia, meaning loss of balance and coordination. Double vision. So sometimes, sudden lang a double vision, it could be a brainstem stroke, or sudden difficulty swallowing. It could still be a stroke. And of course, decrease in sensorium, because the ARAS is in the brainstem, or the ascending reticular activating system is located in the brainstem, and if it is involved, then the patient would present with decrease in sensorium. So nahinumduman na to I hope na-retain at least 99% pag-exam later. But anyways, at least you know how these patients would present. It's difficult to identify stroke patients if you don't know how they would present. Okay? So, let's move on to the risk factors for stroke. So, of course, hypertension. So, katong mga gamentina din, o tambal, please maintain your medications. cardiac diseases, especially those patients with atrial fibrillation. So, di ba sa video ni Doc Art, the patient there had atrial fibrillation, so irregular rhythm in the heart. As mentioned in the video, there are parts in the heart wherein the blood flow is slow, no? So it would cause formation of clots. Pag-pump sa heart, it would throw the clot to the brain and it would cause occlusion there. So it increases the risk sixfold, nako siya. Especially if the patient has rheumatic heart disease plus atrial fibrillation. So the risk here is increased by 18-fold. Other risk factors, diabetes, cigarette smoking, high cholesterol levels, and genetic predilection are those with a family history of stroke. So what are the two types of stroke? Again, we have ischemic and hemorrhagic. So let's look into the ischemic stroke first. So let's start with the case vignette. So a 65-year-old female, hypertensive, diabetic, maintained on telmisartan, linagliptin, atorvastatin, but very poorly compliant. So the patient came to the emergency room here at Adela with right-sided weakness. So the history was, natulog na daw siya asymptomatic. When she woke up, she could no longer move the right side of her body, then she could no longer talk. So she was seen awake, no verbal response with preferential use of the left extremities. So, dugay pa man kay idala sa hospital. So the patient arrived at the ER 14 hours. I-thrombolize? To thrombolize or not? Okay, very good. So the BP was slightly elevated at about 60/100. Heart rate was irregular, rhythm was irregular. The patient was awake, but without any verbal response and would not follow commands, would only move the left extremities. So pupils were isochoric, no? The pertinent neurologic findings was the right side of the face was weak, there was right-sided weakness and Babinski on the right. So what will you order? Unsa may order? What would you request? CBG. Ano na may CBG? CT scan. So you did, so we did a CT scan. So kani, what vascular territory is this? Sige, sige. Volunteer. ACA? Other answers? Oh, kani. Oh, you see the whole thing. This one. ICA. Isa man to, taga na tog medal. So this is ICA territory, diba? Kaya this one, the middle parts, that's ACA, but it involves also the lateral parts of the frontal and parieto-temporal lobes. So this is ICA, okay, both ACA and MCA man. So it's the mother artery, ICA. Okay, smile lang mga naka-correct answer. But anyways, so ischemic stroke, it is caused by an inadequate blood flow to the brain due to a partial or complete occlusion of a cerebral artery. So again, it constitutes 80% of all strokes. So most patients with infarcts, especially big infarcts, even big infarcts, come to the emergency room awake pa. Okay, so if the non-dominant hemisphere is involved, they are GCS15. They're talking, they're oriented, no, pero dako na kayo is like strokes. So you have to really orient or educate the family that they may be awake now, but just what we have to monitor these patients because they usually worsen during the first 72 hours due to edema. So kato, in this CT scan, wala pa kay edema. There's no midline shift. There's already cytotoxic edema, but there's no mass effect yet. But after siguro 48 to 72 hours, this will become very edematous and it would cause midline shift already. Okay, so these patients would have decrease in sensorium. So what happens to the brain cells in an infarct? No? So I heard ka-intimidate an image, so let's break this down. So of course, in an infarct, there is occlusion of the blood vessel. So there is compromise in the blood flow as well as the oxygenation of the brain. So decreased oxygen would lead to decreased ATP production. So if there is decreased ATP, your neurons have ATP-dependent sodium-potassium pumps. So what will happen? There will be pump failure. So more sodium will get in, and you know wherever sodium goes, what will follow? water will follow. So this would result to edema of the neuron, and the cell will become depolarized. And this would cause calcium influx, no? So, daghan calcium mosulod, and it makes the cell overexcited. So that's what we call excitotoxicity. So, aside from that, lipid peroxidases, proteases are activated, and this would digest the cell wall. So if the cell wall is digested, more toxic substances go inside the cell, further contributing to the edema. There is also production of free radicals, which is also toxic to the cells. So this cascade of events would lead to cytotoxic edema, and then later on to cell death. Okay? So that's what happened to the neurons. That's why we really need to intervene right away. Kaya 1.9 million neurons die per minute. So let's go to the cerebral blood flow. So imagine, the brain receives 20% of the cardiac output at rest. So every time the heart pumps, 20% goes to the brain. And if you think about it, the brain only constitute how many percent of your total body weight? Ila naman ang brain. Depende kung unsa ka kuan ang brain, no? So it only constitutes 2% of your total body weight, and yet every time the heart pumps, 20% goes to the brain. See, who has an idea kung sa kabugata ang brain? Guess, in kilograms. Pila ka kilo ang brain? 90 kilo. Bugata. Ay, ligaan na. Pila man. Dili. Dili may mutuwa nga mas bright because even Einstein's brain, guess pila? 1,200. It's lower than the average male brain. So dili dyan na sa ka-bright dun. Sorry guys. Okay. So the normal cerebral blood flow is 55 ml per 100 grams of brain. Ma-picture na ninyo in your head. So let's make a mental picture of this one. So 100 grams of brain is like a size of a matchbox. No? Imagine a brain nga in ani ka gamay or cut of brain, a matchbox cut of brain. That's 100 grams. And 55 cc is like approximately a 50 cc syringe. So every minute, this size of brain would need this amount of blood. So dapat constant every minute. Wala non-stop jud na because the brain cannot store its energy or glucose or oxygen. So dapat non-stop ang supply of blood because it's the one carrying nutrients and oxygen to the brain. So the brain is also amazing because it has the ability to auto-regulate. So meaning, despite fluctuations of the blood pressure, normal blood pressure, malimot o inumutang man mutaas. Despite fluctuations of the blood pressure, the cerebral blood flow remains constant at 50 to 55 cc per 100 grams because the brain has the ability to dilate or constrict its cerebral arterioles to maintain a constant blood flow. Okay. But what will happen if there is decrease in the blood flow? For example, in stroke. Kung maabot na ganing 12 to 23 cc per 100 grams per minute, tissue damage begins. Okay? Kung 10 to 12 na lang, then infarction would occur. So this was already discussed by Dr. Art, no? The two areas or regions of ischemia. So we have the infarct core. In this area, there is lowest blood flow. Imagine the blood flow is only 0 to 12. And it is the most severely damaged. So you can no longer do anything about this region because it's already dead. The neurons here are already dead. But it is surrounded by what we call the ischemic penumbra. So this area, where nakuratan pa ang cells, wala pa sila. Na-shock pa lang siya, they are stunned. So they are dysfunctional but not dead. So this is the area of the brain that we are trying to save when we give thrombolysis or when we what we do when we manage acute stroke, like we prevent hyperthermia or hypotension. This is the area that we are trying to save. So for ischemic stroke, we have different mechanisms. Now we have either thrombosis or embolic. So for thrombosis, it is a local occlusive process. So you imagine this is the cerebral blood vessel. Imagine mo niyang MCA. So, but because of the hypertension, diabetes, crispy pata, lechon, ice cream, there's already accumulation of cholesterol plaques. So this would cause narrowing of the intima and of course compromise of the cerebral blood flow. Okay, and then we have embolic stroke. So there is obstruction. Usually the blood vessels are clean, but the obstruction is by a material from a distal source. So the most common would be cardioembolic. So night AF, there's formation of clot in the brain. So despite having no atherosclerosis in the brain, there could still be blockage because of this material from the heart or the clot from the heart. So again, thrombotic strokes mainly due to atherosclerosis. So they result in narrowing of the blood vessel lumen, and these patients are usually hypertensive and diabetic. But in embolic strokes, the embolus lodges and occludes a cerebral artery, but the source is from a distal source, usually the heart. Okay? And other sources of embolus would be cardioembolic, meaning for AF patients or those patients with RHD, they form a clot here and that gets thrown to the brain. Sometimes it's artery to artery, meaning if you have plaques in the internal carotid artery, unstable plaques, they may get dislodged and then it gets thrown to the brain and causes occlusion there. But for paradoxical embolism, for example, if patients have PFO, patent foramen ovale, or ASD, septal defects, so it bypasses the lungs. Usually the blood gets filtered in the lungs, but if there's paradoxical embolism, it bypasses the lungs, so some clots would go to the brain and cause occlusion there. So other sources of embolus, these are less common: fat, tumor cells, fibrocartilage, amniotic fluid, and even air. So lacunar strokes, these are small strokes. This usually involves the small vessels, like the lenticulostriate arteries. If you remember that these arteries arise from the MCA. So in patients with uncontrolled hypertension, diabetes, it causes changes to these arteries. It causes them to have fibrohyalinoid sclerosis, which would also compromise the blood flow to the areas of the brain that they supply. So they can also be due to occlusion of the openings of the vessels and entry of small embolic material. So sometimes the embolic material gets lodged into these small arteries, causing lacunar strokes. So these strokes are small, they are less than 1.5 centimeters. And of course, their symptoms are also very mild. So they usually, the usual locations are in the basal ganglia, thalamus, pons, internal capsule, and in the deep white matter. So let's now move on to hemorrhagic stroke. So it accounts for approximately 20%. So let's have a case vignette first. 73-year-old male, hypertensive for 10 years, poorly compliant to medications, who came in at our ER due to decrease in sensorium. So GCS7 na. No eye opening, no verbal response, and would only localize to pain. BP was significantly elevated at 220 over 100. So you did ACT scan. So this is what you see. So if this is an intracerebral hemorrhage. So if in part it appears dark, intracerebral hemorrhage is bleeding within the brain caused by a ruptured blood vessel. So the most common cause is hypertension gihapon. Whether it's infarct or bleed, hypertension is the culprit. So there is sudden onset of symptoms that progress over minutes to hours. So it's quite different from infarct. In infarct, sudden, the patient would just say, Dok, nagdungan na dyan, di kalit for weekend akong right arm, nahiwi na din akong nawong slur akong speech. It all happens so suddenly. But in bleed, since it progresses from minutes to hours, so the history would sound something like this. Nakabantay na ko doktor, dibugat akong kamot, pero masaka pa dyan ako siya, and I can still walk properly. After 30 minutes, I was already dragging my right foot. After an hour, di na dyan ko palakaw. It's something like that. Okay, and then they usually complain of headache, nausea, vomiting, and they have decrease in sensorium early in the course of the disease. So these are the common locations now. Basal ganglia is the most common. They could also occur in the lobar areas, thalamus, pons, or even in the cerebellum. So how do we treat this? So for the infarct, the treatment will be discussed later. So For the hemorrhage, dili man kay nato siyang ma-discuss, so I'll just give you a brief treatment for intracerebral hemorrhage. So of course, the goal is to prevent complications and to control the blood pressure. So we would want a systolic BP of 140 or less. And we manage increased ICP accordingly. So we give medical decompressant, so either mannitol or hypertonic solution if the patient needs it. Okay? We give a proper treatment for bleeding abnormalities. If you check the bleeding parameters, if there's any derangement, we correct it. We do not give anti-seizure medications to patients who did not present with seizures. We don't usually give prophylactic anti-seizure medications. But if the patient presented with seizures, we do give anti-seizure medications. And then, of course, adequate nutrition, ensure proper fluid and electrolyte balance. And then, of course, the rest will be discussed later. Okay, so which patients do we refer to neurosurgery? Okay, so it would really depend on the size, extent, and location of the hematoma and some patient factors. So the cutoff volume is 30 cc. So if more than 30, you refer to our friends from neurosurgery. If in cerebellar hemorrhage, we do not look at the cc, but the widest diameter. So if the widest diameter is 3 cm or more, we refer to neurosurgery. Okay. And of course, in clinically deteriorating young patients, but the GCS should be 5 and above. If GCS 3 now or 4, we're actually doing more harm to the patient than helping them. Okay? So non-surgical, of course, katong mga small hematoma with very minor neurologic deficits, ayaw na po to. Ayaw na to po, very high. The blood will just resolve in time, okay? And of course, in patients with GCS less than 5. And of course, kung brainstem hemorrhage, how will you access the blood? So, pontine hemorrhages or hemorrhages in the midbrain, we cannot refer these patients to neurosurgery. They cannot access the blood, so there's no way to drain the blood. So, another case vignette. A 54-year-old female, hypertensive, who came in due to severe headache, as in the worst headache of her life. So, unsa naman eh? Sa subarachnoid hemorrhage. So, only pertinent finding is local rigidity. Okay? So this is how subarachnoid hemorrhage would present on plain cranial CT scan. So this is the very typical, they call this the Star of David. So this is blood in the basal cisterns. Wala nalimta. Ay, nagalimti sa notes. Okay, so patients with the usual clinical presentation would be sudden severe headache, as in like the worst headache of their life. 10/10 on pain analog scale. Kung pwede, 11/10. 11/10 dyan. Wala mo kabantay sa star. Sorry. So this is the star that's why they call this Star of David, because mura siyang star, pero usay mura siyang paki. But they call this Star of David. Okay. So subarachnoid hemorrhage, what is the most common? I think familiar man mo ani kay daghan na tag stories that we hear of mga artista nga kaliter O. So diba, it's the most common cause is an aneurysm, a cerebral aneurysm. So when the aneurysm would rupture, it spills the blood in the subarachnoid space. So common locations, we have aneurysm arising from the anterior communicating artery, sometimes in the PCOM, the MCA, even in the basilar artery and in the vertebral arteries. So one complication of subarachnoid hemorrhage, when there's blood in the subarachnoid space, diba, this is the aneurysm, and the blood spills in the subarachnoid space. This is also where your cerebral arteries are located in the subarachnoid space. So when they get exposed to blood, they get irritated, and this will cause vasospasm. That's why that's one of the complications that we have to watch out in patients with subarachnoid hemorrhage. So of course, if the vasospasm is severe, it would cause delayed cerebral ischemia. So you can have secondary strokes or secondary infarcts because of severe vasospasm. So what do we do for the vasospasms? We give them nimodipine, 60 milligrams, but the drug available is 30 milligrams. So 2 tabs every 4 hours for the first 21 days. So vasospasm usually is very high, or the incidence is highest day 3 to day 9. Okay, so during that time, you really have to monitor your patients. So, of course, we do not give anticonvulsants in all patients, but for those with proven seizure episodes, we give anticonvulsants. We manage increased ICP, and then our BP goal would be 130 to 150. That's acceptable. So the definitive management, of course, it could either be neurosurgical clipping or endovascular coiling. So hopefully, in time, we'll also have this treatment options here in Tanda. So basic neuroimaging in stroke. So, do I still have time? Okay, no. So this is employed to aid in detection or confirmation of ischemia or hemorrhage. So CT scan, we already have CT scan here. MRI, we can also have CT angiogram and 4-vessel angiogram. So CT scan is the most widely available. We order dilitong contrast in stroke, it's just plain cranial CT scan. So it offers rapid initial assessment, especially in patients who are candidates for thrombolysis. Kaya diba, in less than a minute, you can already see the images. Okay, and it offers straightforward detection of hemorrhages. So when you do the scan, when you see hyperdensity na gani, you deactivate na, di na pwede ma-thrombolyze. Okay? And if the cerebral infarction would appear hypodense, and the bleed would appear hyperdense. But of course, the disadvantage of CT scan is that it has low sensitivity for detection of ischemia on the first 6 hours of stroke. So, na-stroke ang patient, 3 hours pa lang, and you do a CT scan, you can't see the infarct yet. You can only see early ischemic changes. That's why in thrombolysis, we only thrombolyze patients na negative ang scan. Okay, dapat wala pa yung infarct na nakita. So, if you see an infarct na magduda na ka, probably more than 6 hours na siya. Okay? So, what is the goal of CT in acute settings? Of course, to exclude intracranial hemorrhage, to look for early signs, and this will be discussed by Dr. Talabukon later. Okay? And to exclude other intracranial pathologies that may mimic stroke, like mga intracranial tumors. Sometimes they present with stroke-like symptoms, even mga abscesses. So aside from CT scan, MRI is also used in stroke. No, it has the ability to detect ischemia with high accuracy. So unlike CT scan, kung early before 6 hours wala kayo makita, in MRI you can already see the stroke early on. So what sequence do we look at? DWI and ADC. So in DWI, acute stroke would appear hyper intense or bright. And then if you look at the ADC mapping, it would be hypo-intense. So you look at these two sequences. So dapat hyper-intense in DWI with a corresponding signal drop on ADC. So this is a clear picture. This is an acute left MCA infarct. So on DWI, hyper-intense, and then you compare it with the ADC, it should be hypo-intense. So that's how acute stroke would look like. And what's nice about MRI, you can also order MRA or magnetic resonance angiography, so you can evaluate the blood vessels. So this is the two internal carotid arteries, MCAs, and then the ACA. So this will help you detect mga stenosis or atherosclerosis, as well as larger aneurysms. So other than this, we also have CT angiogram and 4-vessel angiogram in cases wherein there's aneurysms or AV malformations. But I won't be discussing much on this because wala na tayo time. So let's move on to the stroke scales. This is the last part of our discussion. So I think Dr. Sordilia already discussed this, the Rochier scale. We also have the NICE and then the modified ranking scale. So again, the Rochier scale identifies acute stroke versus stroke mimics. So this is very helpful at the emergency department. So you will know, stroke ni siya or nagpapanggap lang na stroke. So again, you check for the CVG. If the CVG is below 40 milligrams per deciliter, you have to correct it. So it corrects at mo 50-50 before you answer these questions. So of course, has been there loss of consciousness, or was there seizure? And then there's a corresponding score, -1 for yes, 0 for no. And then you move on. Is there a new acute onset of facial weakness, arm weakness, leg weakness, speech disturbance, and visual defect? If yes, +1. If no, 0. And then you get the total score. So, stroke is unlikely but not completely excluded if the score is 0 or less than 0. So it cannot totally exclude stroke, but it is very helpful in the emergency department. We also have this scale, the NICE score, but I won't be going into this into detail because Mamuela will be talking about this later. So this NICE stands for National Institute of Health Stroke Scale, and it gives an objective rate for the severity of stroke. So we have a list of instructions. These instructions are a part of the neurologic exam. And then you have corresponding scores depending on the response of the patient. So this would include the level of consciousness. We also check for the gaze of the patient, visual field defects, facial weakness, motor and arm, leg weakness, ataxia, sensory deficits, language, dysarthria, as well as mga extinction and inattention. And then you get the total score of your patient. So that's the total NICE score. And then a NICE score of 0 to 5 would mean the patient has a mild stroke. NICE of 6 to 21, or even some would say 15, that's a moderate stroke. And if the NICE score is more than 22, it's a severe stroke. So this is also used to monitor the condition or the neurologic status of the patient. Of course, if you increase a NICE score, meaning the patient is deteriorating or there is progression of the neurologic deficits of the patient. And of course, if the NICE score is decreasing, then it means that the patient is improving. And lastly, the MRS score. This measures the degree of disability or dependence in the daily activities of people who have suffered a stroke. So we usually use this scale in post-stroke patients to determine their degree of disability or dependence. So how does this work? So MRS means Modified Ranking Scale. So a score of 0, no symptoms at all, meaning your patient who is post-stroke, wala na dyan siya neurologic deficits, as in like back to pre-morbid state. That's MRS 0. MRS 1, no significant disability. So meaning there's mild disability, but the patient is able to do all ADLs, was able to do everything he was able to do before the stroke. Now that he's post-stroke. So meaning he was able to go back to work. Kung kuan siya, nurse, kung driver, nakabalik siya sa iyang pag-drive. No? So despite the mild disability kay basic, ang iyang deficit is only right-sided weakness na 4/5 na lang. So he can still do everything. Okay? And was able to do all the things that he was able, he has been doing pre-stroke. Now that he's post-stroke, nabuhat na niya tanan. For MRS2, slight disability, unable to carry out all previous activities, but able to look after own affairs without assistance. Meaning, the patient is able to do all activities of daily living except for some. So, basin ko siya. Let's just take this scenario. Maybe he's a driver, but he has left him an option. So, of course, he can take care of himself. He can do all activities, but he was not able to drive again because of the visual field deficit. Okay? MRS3, mostly assisted, but can walk on his or her own. So, kung kaya ang patient makawalk by himself, 3 na siya. Bahalag assisted siya in other things, but if you let him walk, kaya niya mag-walk, that's already MRS3. MRS4 cannot walk without assistance. MRS5 for severe disability bedridden patients. So as nurses, as doctors, our goal would be what MRS? 0. Pero unsa man ang, let's be realistic, unsa may range? 0 to which patients are independent? 0 to 2. Ang 3 kay makalakaw lang per assisted. So, dapat 0 to 2. That's why we really have to be prompt in managing our acute stroke patients because this is our goal. We want to save much of the brain so that ang ilang recovery will also be better. Okay, so we would want an MRS kung pwede 0, 1, o ang until 2 lang. And these are the patients that are independent. Okay? So, I think that ends my lecture. So, take home lang. Stroke is a brain attack. Of course, stroke is an emergency, but what's nice is stroke is treatable and most importantly, stroke is preventable. So I think that ends. Thank you.
Thank you so much, Dr. Yuzon, for that profound erudition. Moving forward, to give us a light about the stroke treatment guidelines and update, a big round of applause to Dr. Jika Patilao.
Hello, good morning. So I'll be talking about how to treat stroke, how to approach. Now that we know stroke din nga pasyente, so sa amin nato ni. So this is what my lecture is about. Okay, so the previous doctors have already discussed what we should know, the basics about stroke. And now, so what do we do next? So Dr. Yuzon has already shown a similar slide earlier. So we should know, so na-establish na nato, this is not a stroke mimic, no? And then we have already known na stroke dini, na CT scan na nato and everything. So now we have to stratify what kind of stroke it is so that we could be able to manage the patient accordingly. So we base the stratification usually, not usually, always, on the knee score. So again, the knee score is a score from 0 to 42. 42 is the highest. And then we stratify patients from mild, moderate, and severe, depending on the scores. 0 to 5 is mild, 6 to 21 is moderate, and knee score of more than 22 is considered severe. So what are the mild stroke patients? How do they present? They are usually alert with any combination of a mild pure motor weakness on one side of the body, or a pure sensory deficit, sensory lang, hawoy lang, or di na nila ma-feel imong pag-test sa ilaha on one side, slurred but intelligible speech, vertigo with incoordination, gait disturbance, unsteadiness, and clumsy hand, or visual field deficits alone. So these usually have scores of 0 to 5. So moderate stroke, they are also usually awake, but with more significant or mas weak lang sila on one side. They have sensory deficits or language deficits as well. Or they could be drowsy, disoriented, but with purposeful response to painful stimuli. So sometimes, tulog-tulog sila, imo silang pukawon, di kayo sila makamata, but when you elicit pain, mo withdraw ra pud sila sa hand kay imo gitest. So sometimes, that is how we check, moderate stroke. And then severe stroke, of course, they are more stuporous. They have deep stupor, or some of them are comatose already. So they have non-purposeful responses to painful stimuli, or sometimes they have decorticate or decerebrate posturing. Or sometimes you see S3 patients comatose with no response whatsoever. So we already have this definition, this stratification. So we stratify them to be able to know, again, how to manage and where we put them that are in the hospital. Aside from the mild, moderate, and severe stroke, we have this transient ischemic attack. They have already mentioned this earlier. So what are TIAs? They are sudden onset yapon of neurologic deficits that disappear within 1 hour and without any signs of deficits in the neuroimaging. Okay, so di kani mga ani nga patients, we don't dismiss them man pod. Nawala na iyang symptoms. Okay na uli na ka. So sometimes these patients would also need to be monitored as well in the hospital. So that's why we also have this scoring system for them, the ABCD score, which takes into account the age, so A, age, BP, clinical features, which are unilateral weakness and speech disturbance, ABCD for duration of symptoms and the diabetes history. So if you have these, if you add your patient's factors, no, you come up with these scores from 0 to 7. So that stratifies your patient between low, moderate, and high risk. And this risk, no, this score would have a corresponding risk of them having a larger stroke in the future within 2, 7, or 90 days. So the higher your ABCD score, the higher your stroke risk will be within the next 3 months. So that's why we also have to stratify. Hindi nga ingon at iaira ni okay ra ni siya. So we also have to monitor and to manage them accordingly. So in mild stroke, no, we usually put them in the acute stroke unit or in the regular room. For moderate stroke, we put them in the ASU or the ICU. Or in severe stroke, we put them in the intensive care unit. Wala pa tayo acute stroke unit here, no? But we put them all in the ICU. No? So hopefully in the future, we could have an acute stroke unit na po. So, this will be the guidelines. So I will belabor the first few slides because across the board, actually, the management is the same. Ang severity lang of the patient and the way we monitor the patient, the urgency of the management would differ a bit, especially sa moderate and the severe stroke. So this is the outline. So how the management priorities, emergent diagnostics, the early specific treatment, and the delayed management and treatment, especially if dili sila mo abot within the golden period of 3 to 4 hours. So, management priorities in stroke in general actually is to ascertain the clinical diagnosis of TIA or stroke. So very important for us is to know the onset of the symptoms. Okay? Because that's when we would know kung candidate pa ni siya for thrombolysis or not. Okay? And then we would also know nga pila na day siya ka-days nag-start sa iyang symptoms. So we ascertain the clinical diagnosis. We do a history, a proper history, and a thorough neuro-PE. So kabalo ba tanan mag-neuro-PE here? So I think we have to brush up on that as well. No, dili lang ka ng vital signs, the physical examination. We also have to do a baseline neuro-PE when the patient arrives at the ER. So next, we exclude stroke or TIA mimickers, no, like hypoglycemia, which was mentioned earlier, a seizure, no, vertigo, a peripheral vertigo. Common also is Bell's palsy. Yung symptom, hiwi akong dagway. Pero pag check mo, both upper and the lower face, the eye are weak, no? So, I think I have a slide later that will show the other mimickers. So, we identify also other comorbidities of the patient. Sorry. So, there is cardiac, diabetes, problems with the liver that would create problems with coagulation, gastric ulcers, because that might be a contraindication for thrombolysis or antiplatelets if na-bleeding. Okay, and then we fusion of the brain. So, kapag mo how to compute for that, no? This is 2 times the diastolic plus systolic BP divided by 3. Then the